Every one of us carries around 1,000 pages of medical history, and most of it never gets read. A big reason why is almost too absurd to believe: the fax machine. Healthcare still runs on billions of faxes a year because for decades it was the one channel that was HIPAA compliant, legally accepted, and system agnostic. But digging through mountains of papers just to find a patient's medical history is about as inefficient and outdated as the fax machine itself. Today's guest is using AI to drag medical records out of the Stone Age and give doctors a patient's whole story before they even walk into the room. Welcome back to Humanify Health Tech, where we explore how AI is rewriting the rules of healthcare and putting people back at the center where they belong. I'm your host, Brian Chee of NetHealth, and today I'm joined by none other than Carm Huntress, founder and CEO of Credo Health. Credo uses state-of-the-art AI to give doctors a complete, accurate picture of the patient in front of them, instead of a stack of disparate fax papers. Before Credo, Carm built RxRevu into the largest real-time cost transparency network in the country, serving 250,000 providers and 700 hospitals. He's the rare founder who's already fixed one piece of healthcare's broken plumbing, and for some reason has decided to come back and fix another in healthcare documentation. Carm, thanks for joining us today.
Yeah, thanks, Brian. Thanks for having me on the show.
I almost laughed at the intro because just referencing the fax machine and the idea of that is a little bit absurd and a little bit ridiculous.
Yeah, no, I think you're right. And I don't know what your second thought there is, but I'll start off by saying, it's a big reason I started the company. And, the idea, there's a story behind it that I love to share about my mom who had cancer in the 90s. And, she went to all these specialists and she'd take her medical record. And back then she used a typewriter. She actually used to type up a summary of her medical record to take to her next appointment because it was all over the place. She didn't, needed to pull it all together for her doctors. And I think maybe we've moved beyond the typewriter, but definitely not beyond the fax machine. And, it's crazy to me in 2026, we have this, blossoming and this incredible moment of AI that's happening. And yet you and I don't think I've really met, I've met maybe a handful of patients, I think, that could say, hey, I have my complete medical record. Nobody really has that in a world where your financial data, your emails, you pick, your drive, all your files are all, you really have all that stuff in one centralized place. And we could easily argue it's the most important thing that a person can have is their complete medical record. And yet we don't have the systems or infrastructure in the United States and still heavily rely on fax to get all our medical record data together.
So that's interesting because not too long ago, I actually got my full medical history and put it together. And the journey in doing that was frustrating. It was agonizing. It was all the words you can just toss into that pie, right? It was terrible, just a terrible thing. And here's the thing: you're talking about your mom there, and here's the thing: that was 31 years ago, and we're still here. How is that possible?
Yeah. And you kind of think about the arc of technology that we've been through, right? The internet emerged, we had Web 2.0, we had mobile, and now, this whole blossoming of AI. And yet this is still one of, I think the biggest technology challenges that we've ever seen. And another thing that I think about a lot, Brian, is, technology is supposed to be the most deflationary effect, right? It's supposed to lower the cost and make things more efficient. And in healthcare, it's the only place where we've heavily introduced technologies, especially even through government incentives in terms of meaningful use and EHRs, where the cost has dramatically gone up. And we still have these systemic issues going on, even though there is, a lot of technologies. And I think just like your experience, so many patients go through this struggle of, hey, I need to get my medical record together. I think you guys probably all know Chris Klomp, and I was just at the Aspen Health Festival a few weeks ago, and he was on stage, and this is the guy under Dr. Oz, basically running a huge swath of healthcare now, as I think he just took the role as the undersecretary. And he's on stage talking about a life-threatening condition that his wife had. And she needed to go see a specialist pretty immediately. And the referring physician actually faxed her record to the wrong doctor. And they still don't know where it went. They just faxed out into the ether. So not only did someone receive her whole medical record, we don't know who, it went to the wrong place, and it delayed, really important care for her. It was a big deal. And Chris was just sort of pointing to the fact that even as, someone as an administrator is feeling it on a very personal level with a family member, dealing with a fax, issue, which is kind of an insane thing to say in 2026. So it's still very much out there. I think people are more aware of it today than ever. And I'm hopeful we are on a path, I wish I could say years, but I think more 5 to 10 years probably to get there in terms of infrastructure in the US to make that transition to digital and sort of complete availability for most consumers to all their records from all the providers and doctors they've ever had visits with.
So you mentioned in a podcast you did last year in Money Stories, which, by the way, I suggest anybody go find that. It's a great interview. It's deep and long, and it's just a really great conversation. But you mentioned in that interview the concept of being a craftsman, and so what you just said there about the role of technology and what technology is supposed to do makes me think of that, because a technology craftsman, somebody who's a technologist, who is a craftsman at that work, wants to initiate that deflationary process, right? What's keeping them from doing that? Why? What is it? Just that it's built it's just that we in the medical world are built on an infrastructure that doesn't work. What is it that's keeping those craftsmen from doing their work?
Well, everything really, let's just to start off with some simple concepts, right? Where is everybody's medical record stored today? The infrastructure that was built under meaningful use created electronic health records. And, those incentives allowed, providers to very quickly adopt pretty much any technology and any solution. And so, you could argue, I've heard as many as 350 to 750 different EHRs just on electronic health record side. There's other systems that store imaging and things like that are part of your medical record, like if you have an MRI. But just the raw sort of, notes and labs and medications and all that stuff is stored inside electronic health records. And for better or worse, those systems that were built by not great technologists. There were so much incentives. Anybody could kind of build an EHR and get it out there. And the way I look at it is that there was this perverse incentive where the government was paying doctors to go on EHR. So it didn't really matter. They didn't sort of qualify them or say, you're the best system. And I think also that HIPAA did slow down some technologists in getting into health tech, because it was a scary place to sort of go, manage someone's personal health information, their PHI. And so we had this proliferation of EHRs, starting in, the mid 2000s through today. And so you have this hodgepodge of EHRs that are, antiquated or running on old technology. I mean, the biggest EHR player in the United States is Epic. Their core underlying, code is MUMPS, which is, something from, the 80s, essentially. It's a very antiquated, way to write code compared to what we have today. And so those systems are what you have to connect to pull out all your medical record data. And the government started a process maybe a decade or more ago now through these what we call national networks, and connecting electronic health records systems and health information exchanges at a state level into a national network. There's sort of three major ones I think I would mention, which is Care Quality, Commonwealth, and the eHealth Exchange. And then, trying to wrap regulation around that for different types of use cases to get data. And then finally, we've rolled that up into something called TEFCA now, which is the Trusted Exchange Framework and Common Agreement, if you like a word salad, to put that all together. And so we've been on this march, right, to slowly start to put together all the data. And the hard part is those underlying EHRs, there hasn't been, I think there's been some carrots, but I would say not enough sticks to get them and mandate them to put that information and make it available both for doctors that are treating patients and need all their medical history, as well as patients like you and I who just want to request it from them. Now, there's a lot of technical stuff that behind the scenes that hasn't come together or needs to come together to make that happen. But I think that's really the underlying thing, is that, we got all these EHRs set up, and we just didn't create and haven't created the right incentives. And just to bring this home to the work we do at Credo, we spend a lot of time trying to get to completeness on patients. We look at claims data, we look at eligibility history, where your insurance was run, to kind of get telemetry of where you got care. And I can tell you pretty definitively that for most patients we touch digitally, we can only get to about half to 3/4 to about 75% of their data. And the rest is missing. And the rest is with kind of one-off specialists, right? Cardiologists, endocrinologists, oncologists, that are those specialists that haven't connected to these networks. But in some ways, this is the most important data missing for most patients today.
So isn't that an interoperability issue? Isn't that a challenge with interoperability first and foremost, what you're talking about? How does Credo play there as far as, and this is a super basic understanding of it, so correct me and educate me, please. I think of interop as sort of the pipes that fit everything together, right? Right.
Mm-hmm.
The data is the water that flows through. You're actually making sense of the water. In my world, Net Health, which is a specialty EHR provider and digital intelligence or data intelligence provider, we're in this world as well when it comes to rehab therapy and wound care, right? We're providing that water through those pipes to all of the various organizations and specialists who need it to connect, to create that connectivity. How does Credo play in that? And do I have that read right?
Yeah, I mean, we care about the pipes, and we'll do anything to go through different types of pipes, even if you want to call a fax machine a pipe, right? To get that data, the water flowing to us. It is an interoperability challenge, but as I said, there's, not enough of these, sort of medical record storage systems, these electronic health record systems are connected to these networks today. It is, there is a lot of data flowing through them, but it's insufficient. It's not even close to completeness in our point of view. Now, we at Credo sort of do three things for providers today, and we work a lot in value-based care where having completeness really matters. If I'm a provider group and I'm getting a fixed amount of dollars to take care of a patient from a insurance or payer, I'm sitting there trying to see their whole picture, and I want to see everything about them. So that matters a lot. So we do three things. The first thing is we go get all that data. We've done a lot of science and AI, sort of matching technology to know here's a place through a claim where you got care and we actually have the record or we don't. And do we need to manually chase that record? We actually have an entire team, believe it or not, that even goes on site. We actually have people that fly around the country and go on site to go get medical records if there's enough of them at a particular site, and they actually get handed stacks of paper and we scan those in. We pay over on an annual basis, well over seven figures. I don't want to give the number away, but well over seven figures in copy fees, believe it or not, Brian, still today, right? We're paying a huge amount of money just to get the paper version. We'll scan that in and then match it to the patient's record. So that's number one. And a lot of, provider groups don't want to go through that hassle of chasing down all those different charts and, even the digital ones coming through, as you say, as digital water coming to us. Don't want to do that. The second thing then we do, once we put it all together and normalize it, we put it into context for an AI, we pull out an insight. And we do all sorts of insights today for different, use cases. The best example we do today is diagnosis discovery, and we can talk more about our model and how good that is today and what we've seen in the last year in terms of models getting better at identifying diagnoses, either, predicting diagnosis or even seeing existing diagnoses and how it's getting better than doctors. And then we surface that insight to the provider and either show it to them or actually take action on their behalf at the point of care. So our tools are integrated in the HR and we're surfacing these insights saying, hey, we've got some data here we want you to look at that we found through the pipes, right? That we either, maybe phone and fax for, maybe we pulled it through the digital, interoperability of the national networks. Here's the AI identified this net new diagnosis. We think you should treat it. And here's the clinical chart to go with that. and then enable the doctor to make a more informed decision on that patient. And there's no way a doctor, in let's say a Medicare patient that's 65 or older, we're touching 1,000 pages of history. That doctor's not going to scan through 1,000 patients, pages of history before the visit to pull out that insight that we're delivering at the point of care. So that's how you want to think about our platform at Credo is, we get all the data, we pull out insights, and then we bring that insight or take action around that insight on behalf of the provider to ultimately save them time, but also improve the quality of care and the outcomes for these patients that we touch every day.
That's interesting. So essentially you pull together what you can out of an antiquated system. And by the way, if we use the pipe analogy, seriously, the fax machine is a bucket, right? That's where
that you carry.
Yeah, that you carry around. You pull what you can from this sort of antiquated system that wasn't really built strategically at all, right? Then you also pull out the what you anticipate to be the most needed areas and most needed data points to help the physician, to help the specialist, to help the clinician find that diagnosis and help the patient. Okay. So obvious question number one is, how do you do that? And is that all AI? Does all AI do that? You mentioned a sort of human AI sort of collaborative, which we find more and more. How does that work with AI, man? That's fascinating.
Well, we went through a phase over the last year where we were using humans in the loop, what would be called medical coders, to look for those diagnoses. And what we saw in the last year is really a phenomenal change. So many people have sort of seen this, right? Where, if you were using Claude or, OpenAI and ChatGPT, you might have saw, certain, improvements that were pretty mind-blowing in the last 6 months. And so did we. And so we were using humans in the loop. And what we did is we built, basic evaluation sets of, here's a set of coders and here's a set of doctors looking through charts. And we gave them unlimited time. We paid them a lot of money to go through hundreds of patients to give us an evaluation set to say, hey, now we can take an AI model, see how well it does on the same set of patients and see how good it is. And I would say, last year, there's two kind of variables we look at really closely, which is called precision and recall. So precision is how accurate you are. Was there a true diagnosis? And recall is, did you get all of them, right? Did you find all the diagnoses? About a year ago, Brian, we were probably in the 40% tile on both those metrics in terms of precision and recall. A coder could get to very high, precision, like 90, 95% precision, very good at codes, and then hit out about 55%. So get half of the total recall in terms of finding all of the codes. Now that makes sense. I'm really good at a small set of things, very human, right? Doctors are kind of just a little bit broader than that. They get to about 70, 75%, but still high accuracy, right? Sort of 90, 95% accuracy and getting to about 70, 75%. What happened starting in the fall of last year is that we were plotting, this recall and precision with the AI, and every model that came out, we saw a substantial leap. And we could start to draw a line. We sort of projected out and said, wow, we're seeing this improvement, doubling, improvement or even more than that in the model's performance, right? That was drawing this kind of line for us. And we could project out and say, wow, within a year, if this thing holds, we're going to not only supersede coders, but beat doctors. So what I can tell you is that came true. So now what we have and what our AI model can do is it's about 80% on accuracy. So it's not at that 90, 95%. We're still about 10% of the way. But what's so interesting, in the last 6 months, it has exceeded doctors in finding diagnoses to a point where we had to go back to the doctors and say, can you check these? Because you said this wasn't a diagnosis and the AI model said it is, yes or no. And they said, no, that is, I missed it. So we've seen now where we were about 70, 85% with doctors going through, we're now at 80% in terms of finding the total diagnosis. And this makes sense because a human, right, has no matter how good of a doctor, we manage, give or take, 5,000 diagnosis codes, right? They probably roll up into 80 or 90 main conditions that kind of span out on a very detailed basis to probably 5,000 different codes, right? Diagnosis codes that we track. So, you go, a doctor's just going to tap out somewhere. They're just not going to have, they're not going to be able to cover that breadth and depth. And that's where the AI can really take over and get to that 80%. So we are in really a new world era. And the last thing I'll leave you with is just incredible is just compare it. Now, medical coder, right, is at 55. We're at 80, almost 30% better. What's fascinating is that cost, I can tell you it's less than a factor of 10 to do the exact same work. So this idea, this is where people have this fear of AI taking over. Well, think about how many medical coders there are in the world. Right? This is a pretty big profession worldwide. There's huge companies. If you know Gebs, they have like 12,000 people that do different types of medical coding. This is an area where I think AI will easily, take that over within the next, 3 to 5 years.
So extrapolate that out for me a little bit. What does that mean in terms of humans and AI working together to provide better outcomes? That's a big deal. It's a big deal. It's what we're all about, I know. And as I know from listening to your podcast and reading your work, it's what you're all about is essentially AI and humankind finding ways to be more efficient and to actually heal people, right? Put the power back to the healers. That's, I think you even said that. How does that work? Extrapolate that out and tell me what that vision is in the path that you're on.
Yeah, I think that what people miss a lot, and I think we're not talking about enough within healthcare, is that where we want to take doctors and people clinically is, from being authors to reviewers. And I think that's the best, healthiest place we can, put them. If you think about, doctors are doing, tens to hundreds of hours of extra work a month on administrative tasks. And we've got to get them out of that into having AI bring forward the most important information and allowing that provider to be a reviewer. The thing I'm very cautionary about that rhetoric and that thing is that there's some data, and it's concerning to me, that's showing when you bring the doctor back in, the performance and outcomes actually get worse. The doctor guides it in a bad direction. And I think this points to, I think it's a system problem, but I also think it's a bit of our educational system in the healthcare industry, in that, doctors are 12 years behind, right, the standard of care in the United States. We have to dramatically change that and close that gap. AI can help them do that. But that's leading to bad sort of rote memorization decisions on behalf of patients that aren't up to snuff in terms of the doctor performing at the top of their license. So we've got to work with AI and have systems say, the AI says, hey, I know this is what you've done for the last 30 years, but here's the evidence, here's the guidance. I want you to be the reviewer of this and make the best decision for the patient. But I want you to have that curiosity to change the way you've been practicing medicine. And I'll tell you a story that I love to tell about this that I think really points to how systemic this problem is. When I was running my last company, RxRevu, which became Arrive Health, there was a study I saw on prescription behavior. And what they did is they took Medicare claims data on a doctor basis, and they looked at their prescribing patterns. And they were, with 97% accuracy, able to tell the doctor what residency program they went to from that data. As far as 30 years back. So just pause there and you're like, oh my God, you're telling me I could just look at the prescribing pattern of a doc and with 97% accuracy up to 30 years ago say, you went to this residency program. And so we just, this is the problem of rote memorization. And hey, I went to, XYZ residency program and just got it hammered into me. And this is the way I treat patients in this way.
And so data intelligence at a whole nother level, right? It's this concept of being able to identify patterns. And we talk a lot about that, right? Identifying patterns in the noise, identifying patterns in behavior is where AI plays an especially important role. Is that right? That's what you're doing, essentially.
Totally.
And that's kind of Credo, right? Yeah.
Yeah. And I think that's what we're really trying to do at Credo is like, I want to create a system that's there, that guidance system with the doctor that's bringing forward the most important things for them to look at, and then letting them be the reviewer with the ability to level up, with the ability to improve their intelligence and understanding. and knowledge gaps they might not have of the best clinical evidence and guidance. And we have to make their job so much easier. You know, Vinod Khosla wrote this great paper many years ago that I read that I love, which is, I think it's called 20% Included, where he basically said, we got to create a world where 80% of the work is done with AI. And he actually didn't label it as AI, but he said technology is like 80% of the work. And then the doctor is that 20%, right? That doctor is the human empathetic thing, human to human, talking, having that social interaction with a patient, and really identifying and working through the most important things for that patient in a highly empathetic way, right? That, is really getting them back to being doctors. And I think, we have the systemic issue of not enough people getting into medicine. And I think this is the other part that I love about AI. I want to become a doctor in this like new, amazing like world, right? Where you have this like Jarvis-like experience, right? Imagine that future state for a doctor and how incredible that would be, right? To walk in and you have this agentic partner, you're working on patients together, you're coming up with the best ideas, you're solving problems, you're trying different things to really heal them, right? And I think this is the other big thing, I am really hoping, especially with the focus on longevity, this combination of, new therapeutics that are really about curative and preventative instead of what we've had to date, which is really, I'm going to treat the symptoms with, prescription drugs and really attack symptoms and sick care, as we call it in the United States. That's the other big part that's so exciting. And the trajectory, we're not only at Credo, but I think, across all of healthcare and digital health in particular.
Okay, I got a couple of questions I'm going to ask you back to back here. But the first question I'm going to push back a little bit because I want to understand what the doctor does. So you said a couple things there. You said, the doctor is this empathetic voice. The doctor is the empathy in the room. First, then you talked a lot about curative and preventative care and the coming change in wellness, let's say, right? Healthcare instead of sick care. We're now moving into this era of healthcare. That's all wonderful, great. Well, what
yeah, it's a hope.
Yeah, right. Hope. What does the doctor do then, right? Is the doctor, I don't think that my doctor would, well, first of all, my doctor doesn't have a lot of empathy. I'll just be honest with you, right? Mm-hmm. My doctor is just a curmudgeon to the nth degree. So he's going to be out of a job, first of all. And secondly, I think most doctors who want to practice at the top of their license are going to be like, well, wait a minute. My job's not empathy. My job is healing. How does that jive?
I think, we got to sort of start off as like, what's that future state and what's probably the best likely outcome here that's going to be incredibly positive for patients and for providers. And I think it is that, agentic partner for the clinician to be sitting there working through, a patient's case and having that thought partner to figure out what the best treatment path is. But they have all that sort of intrinsic, hey, I've seen this patient for many years. And the other piece that I'll really lean on here, Brian, that I think is not talked about enough is that we have to, and I'm really talking to the administration a lot about this, is that we have to make a full-hearted push into value. And here's the reason why, because, to your point, this is a hope that we end up in this preventative wellness, longevity point of view. Well, the system today under fee for service is not built for that. Now, I will tell you, I'll tell you the scariest thing that I've heard in the last 6 months. I know of a doctor and his wife works or a guy in healthcare, and his wife is a endocrinologist. The hospital is restricting her from outpatient care because they don't want her giving patients too many GLP-1s because it's pulling away from their surgery and gastric bypass business. Now, I think that's illegal, and I think that she should whistleblow on these guys. And I said that to him. I said that is insane because you have patients now that can take a GLP-1, lose a bunch of weight, and they don't have to go through gastric bypass, and that's a huge revenue generating thing for hospitals. And so the challenge we're up against is in today's world, if I deploy AI in a fee for service, it's just what all the technology to date has done, which is we need to drive more revenue, right? The AI is going to try to push those billing codes to the absolute max and then send those bills to the insurance company that frankly is just going to turn around and deny those claims with their own AI. And now we're in this war, right, of AI fighting each other. I'm going to try to max my billing because I'm, a hospital that needs all the revenue I can get. And I run on razor thin margins. And then I have payers fighting up against that. Now, if we could come together under value, right, which I spend most of my time working with outpatient, fully capitated Medicare Advantage groups, right, that are incredible. And I would say deeply care underneath the hood. They're trying their best to take care of, in a lot of cases, seniors, in the best possible way. And I look at that future, and that's the future I want, where the provider, the hospital is getting a fixed amount of money, and then they're sitting there with AI trying to figure out, how do I best take care of Brian? And because I only got this much money, right? I only have this much to play with. And my job is going to try to get Brian to be as healthy as he can, right? Because then he consumes as little as healthcare costs as possible. And I make as much money as possible. And so I'm, part of my goal and vision and work I do is trying to, I think we're trying to set an example with our, as a technology partner to value-based care providers to solve this problem. And then I look at that outcome where doctors are motivated, incentivized, and the system is whole in terms of wanting to do the best on a patient's behalf. And I think that's the system we've got to sort of fight our way towards, because if we continue under fee for service with AI, I think it's going to be one of the, costs will only keep going up, $5-6 trillion of cost in the US. But that's my, I'll get off my soapbox and let you
No,
ask
but
me some questions.
It's interesting. The bigger point that you're saying there, I think, is that, however good Credo is and however good companies like Credo are in terms of flourishing the right data up to the top so the providers can use it at the right time, if it's in a system that doesn't work, or if it's in the wrong system for that type of data profile, it's not going to work. That's essentially what you're saying, right? So it's like, totally. you can fix the engine of a car, but if the wheels aren't on, ain't going anywhere. That's and
it's really an incredible opportunity. I mean, if you think about what I kind of look at the combinatorial effect here, right, of, national interoperability. If that truly comes together, we can get to complete medical records. Now we have AI going through all that data. And then the third piece is, we haven't even started to see sort of AI breakthroughs in, therapeutics and what we're going to see on that side. I think GLPs are an early sign, but those weren't even really AI discoveries. They really came before, if you think about tirzepatide and Ozempic and these drugs that are truly lowering obesity rates in the United States. But what's going to come after that is going to blow all our minds, right? I think Calico had this cream last week. They've come up with this enzyme cream that will turn your skin back, from 7-year-old skin to 30-year-old skin. It's like crazy stuff that's happening out there. And that combination of those things coming together creates this incredible opportunity for us in the US, right, to totally change the health of Americans. I think the challenge is that the incentive model is completely broken under that, right? We are not going to see those things come to bear in the way we want, because, if I go to a hospital and I said, I'm going to cut your surgery rates by 50% because I have this AI thing that could just better take care of patients. I mean, the hospitals are going to revolt, right? Like they absolutely need those things to survive. And, this is the stuff that I get really frustrated when I see hospitals building new wings and more hospital beds. And it's like, no, care is moving outpatient. Hospital stays are going down. We should be focused on more outpatient preventative care, not more hospital wings, not more hospital beds. We don't want people in hospital beds. We want people at home, with the best AI helping them live their best life. Right? Like sitting in a hospital bed is terrible. And we should not be, and this is where I think hospitals and, as a guy on my board used to say to me, we have to find the coalition of the willing to go, and the cultures, the hospital cultures that are going to go pursue these things in the right ways.
This is a great conversation because we are 3,000 miles away from where we started, but we're actually next door because it's so relatable and so close to home as far as what Credo is and the whole idea of how AI works to unveil people's medical history and medical health, right? Their healthcare. Let me step back though for a second, because what you're talking about are these large visionary visionary stakes. Credo is based on something that's fixes a problem, in my opinion,
Mm-hmm.
right?
Yeah.
It's a solution to an acute problem. In that podcast that I mentioned earlier in the show, you mentioned that you were doing Credo for yourself, that this
Mm-hmm.
was for you, you said. And on top of that, you talked about the idea of your values driving Credo for you as a craftsperson building something. My question to that little preamble is, what is it that you're building through Credo? Are you building a better healthcare system, or are you building a better data system?
Yeah, I mean, I said on the podcast, and I'll say again, I'm on a mission to heal people, and I think that the the arc of my story is very personal in that I didn't only lose my mother to cancer, but I also lost my father. That's at age 7, I lost my father, and age 15, I lost my mother. And the arc was very tough, and it drove me a lot into entrepreneurship and wanting to solve problems. And I'm so happy I got into healthcare because I saw how this is back in the 80s and 90s. This was pretty bleak back then. I think cancer care has come a long way. But I will share with you, Brian, that I've actually gone through my own cancer journey. And luckily, I've been very preventative, and I've stayed on top of it and been as healthy as I can. But I did get diagnosed with a very early form of lymphoma last year. And I'm happy to say I went through treatment. I'm cured. I'm in remission. But it was a huge journey for me. I flew all over the country. I met with some of the best specialists in the world, and got incredible care. And I obviously have a lot of access that other people's don't. But I would tell you, and it really comes home for me, is I was at one of the best medical centers in Boston in the world. And I'm sitting at the front desk, and talk about a call. The woman's checking me in, and she looks up to me and she says, "Carm, did you bring your CD-ROM?" And I was like, "What are you talking about?" And she points behind me, and right behind me in the lobby of this beautiful building in Boston is a sign that says CD-ROM intake desk. And I'm sitting there like, God, I'm early stage. I'm fine. They caught it very early. I'm going to be okay. And I'm not about on my deathbed here. I'm not facing really a life-threatening situation because I'm going to get this taken care of. I couldn't imagine. I forgot my CD-ROM, right? And now what? The doctor's not going to see me? And you're the best, top 3 in the world, and this is what you're offering? And for me, it just hammered it home. I literally stopped in my tracks, and my partner Kirsten was with me, and I said, "This is the reason why. This right now is the reason why I want to build the thing that I wanted as a patient when I got diagnosed. That's what Credo is really about. And I want my doctor, when I walk into that room, to be absolutely fully informed and know everything about me so they can deliver the best care and make the best diagnosis and treatment decision for me. And I want that for everybody else, right? Because that's what we don't have. And so that was this is, to me, back to, it's so deep for me, and I look at the arc of my story through my parents to what I do now and the contribution I could make and the impact I could make on patients' lives. And I can tell you, I had terrible leg neuropathy and all these, issues going through treatment. And to get up every day, and I can tell you I had days where I couldn't get off the couch. I just couldn't do it. And it was very hard to show up as a CEO, and I had to kind of pull my hours back. And it was hard because I love the work I do. And God, it's the first time I've been physically depleted. And I was just sitting there like, God, I want people to live, nobody can live their best life if they're, depleted or have a chronic condition that doesn't let them show up every day or in chronic pain. We have to solve these problems. And, I felt it firsthand, and I know how much it sucks to have that taken away from you. And so I'm really on this mission in such an incredibly deep way now to create this thing with Credo to really help doctors in this way, and help patients as well. And God, how lucky and how grateful should we all be in this moment, because AI showed up. There wasn't an answer. Literally, when I started Credo, I was just like, let's go solve this medical record problem. Maybe some good things will come or whatever. And then this beautiful thing in AI showed up, and we have this opportunity. It's our moment, all of us, who are in healthcare doing this work every day to grasp this moment and go for it and actually fix this system and switch it to value and get away from sick care and end chronic diabetes, obesity, cardiovascular disease, cancer. We actually have a fucking shot, right? Let's go for it together and make a huge change.
And in a way, it's your judgment. You don't even know your judgment is leading you to that point, and you may not even be aware of it. And by the way, the greatest tribute you can give to your parents, to your loved ones, is to do something that matters and makes a difference through your own journey and your own story. Doesn't matter if it's big or great or small or not, but it just matters that you're utilizing yourself and who you are to apply that to something that's bigger than yourself. That's an amazing story. That's an amazing story. Thank you so much for sharing that.
Yeah, thanks, Brian. I really hope I inspire others to get into healthcare. Yesterday, Y Combinator had this big launch and they had 6,000 entrepreneurs. We need so many of the best minds right now to come into healthcare and solve these problems. This is, like I said, it's our moment. And for better or worse, not the best technologists have come into healthcare in the past. And I think these great minds we have now and what people can do with AI are really setting this up for all of us to succeed in an incredible way. And I try to stay as optimistic. Some days are really hard and frustrating and it's slow. It's still not as fast as I'd like it to be. But ultimately it is about, that journey and really, as I said, trying to build something that I wanted as a patient for my doctor, and to really have that complete record at their fingertips with AI and have that agentic experience of figuring out what's the best way to treat me as a patient and then having that empathetic conversation. And that's the world I want. And I'm going to try my best to help doctors get there. I'm really inspired these days in the progress we've made and I've seen other companies make in the space.
Wow. Well, thank you so much for this conversation. I have so many more questions, but I'm not going to, we're going to have you back. I'll ask more questions there. Just thinking about where Credo goes from here is inspiring in and of itself. And I think this is the perfect spot to put a capper on this conversation, TBD. But thank you very much for taking the time to share your story and to talk about what you're building at Credo. I think, I think it lets us connect to that larger universe. And that's the most important thing of all. So Carm, we're going to let you jump and dive into our recap segment. So thank you again for your time and for your stories. And we'll see you again.
Yeah. Thanks so much, Brian. Thanks for having me on.
Thank you. All right. Recap time. Here are the top 3 things I took away from my conversation with Carm today. First, the record access problem isn't new and it isn't unsolved by law. The Cures Act already made access a legal right. What's missing is practicality. Getting a record and being able to use it in time to matter are 2 different problems, and only one of them ever got fixed. Second, the problem was never really getting the record. It's getting a usable record in time to matter. 1,000 pages of faxed history you can't search is functionally the same thing as having nothing. In fact, it may be worse than nothing, especially when the clock says 15 minutes. Credo's bet here is that AI's real job is comprehension, turning a mountain of unstructured paper into a clean, complete summary a doctor can actually act on before the patient sits down, so they're prepared and the patient feels cared for. That's the solution the whole space has been missing. Finally, craftsmanship over mandate is what Carm credits for actually moving this forward. A law can require a system to exist. It can't require someone to refuse good enough. Whether that same instinct scales is another question. Will it scale beyond one founder across an entire company serving millions of patients? Well, that's the open question he's still answering in real time. And that should do it for today's episode of Humanify Health Tech. As always, thanks for tuning in. If you're joining us on Spotify or YouTube, we'd love to hear your thoughts in the comments. Don't forget to leave us a rating while you're there. Once again, I'm Brian Chee from NetHealth, and I'll see you next time.